think we can start. Hello, everyone. Good morning or good afternoon. It's a pleasure once again to welcome all of you for this new IWC Symposium. Today, we will have two very interesting cases of complex wrist trauma. The first one from Santiago de Chile, presented by Paula Ramirez and Rene Jorquera. And the second one from Buenos Aires, presented by Noelia, Montenegro, and Gustavo Gomez. So I would like to thank all the colleagues who joined once again the discussion and accepted to join the panel. I would like to remind you the rules of the webinar. It's an interactive webinar, so please feel free to post any comments on the chat, to ask any question, and to answer the polls. Gustavo and Lucian will manage the chat today. So we have from now about 1 hour to discuss the cases, and I can see Paula already shared her screen. Paula, we can start with your case. Thank you. It's okay, Paula? You can start.
Yeah, okay. That's it. So can you see my screen?
Perfect. We can see it. Thank you.
Yeah, okay. So hello, everyone, and thank you again for this invitation. So we're going to start with the first case. This is a 41-year-old right-handed man that works in the events production industry who was involved in a motorcycle accident, having a thumb and a wrist hyperextension. So these are the x-rays, diagnosis. Do we need more study? Anyone wants to comment?
I think we can ask someone, our colleagues. Someone would like to comment? Our young colleagues, we have.
I can comment. Hi, my name is Z from IWC Paris. But from this X-ray, I could see that there is there's a PA as well as lateral view. On a PA view, you could see very obvious that there is a radial fracture, and there is a sort of a ulnar translocation of the carpus on just the pure PA view. And on the lateral view, you can see that there is a dorsal dislocation. So there is a dorsal radiocarpal dislocation of the wrist. So in this case, I would say that it's radiocarpal dorsal fracture dislocation of the radiocarpal joint.
Thank you, Zé. I can see Mohd would like to add something, maybe?
Yeah, my comment is like previous. There is a radiocarpal dorsal radiocarpal dislocation, radial sterlite fracture, and I can see also there is maybe involvement of a radial column and intermediate column of the radius with some overlap of the bone. So I think better for us to order a CT scan of the wrist for better fracture configuration and better preoperative planning for this patient.
Okay, very good. I agree with you.
Sorry, Paula, I can see Tadeusz Dimitri would like just to add a small comment. Tadeusz?
Yeah, just a small comment. If this previous X-ray was also involved in the case, so there was a fracture in the first metacarpal, so just not to forget that.
Yeah.
Thank you.
Right. That's the fracture of the first metacarpal too. So these are the images of the CT scan.
Do you have any other views of the CT scan? Or?
No, these are the views that we have. If anyone wants to add other comments.
Tadeusz, you hold.
Okay, if you just like, so well, obvious luxation, what we have mentioned before, and it was really worth to do a CT scan just to see what about the nature of fracture of radial site on radial bones. So we have bicolumns involved. That was not so obvious from X-ray. Yeah, this is the most obvious thing. What else?
What about the fracture?
Scaphoid. So if you look, if we look at the small fragment of the scaphoid, that might be interested, and what we need, obviously, we'll need to address the bicolumns from radial radius. So this is the most important.
You see a fracture on the scaphoid. It's not really obvious for me for the moment.
Yeah, on the coronal slice on the right upper corner. And so you see some. Okay, if there are different, so maybe there are other slices, but probably there is kind of a little bit of scaphoid fracture, but it's not the main problem of the patient, of course. Yeah. The main problem is luxation and bicolumnar radius fracture.
Thank you. I can see we have Pedro and Francesca, Madrid. They are very dynamic today.
Okay. I think it's a nice case, but probably, in my opinion, it's mandatory to perform an X-ray in the emergency room and also an CT scan. But in my opinion, probably I try to do first the reduction of the fracture dislocation, and then prepare a CT scan. Why? Because probably the CT scan after reduction, you have many information about instability or other fragments. Probably it's only my opinion. Probably in this case, I try only 2 X-rays in the emergency room. The first one before the reduction, second one after reduction, and then I try to perform the CT scan.
Thank you for your comment, Pedro. So for Pedro Delgado, reduction and after in emergency. Thank you. Francesca, you wanted to say something, please?
Yeah, hello everybody. I definitely agree with Pedro. I would try reduction in the ER, and then I would perform a CT scan. And about the little scaphoid fracture, it looks like a ligament avulsion to me, like the insertion of the scapholunate ligament. It's probably ruptured, and this is the little fragment that we see. And also probably the extrinsic or the dorsal extrinsic ligaments are also torn. That is also important.
Okay, thank you. We take a comment from Logan, Canada.
I agree with Pedro that doing the reduction and then having a CT scan, but also from the perspective that sometimes we're very excited about the case and what it is, but there's also a patient on the other end. And so it's a nice way to help reduce some of that pain and reduce the amount of medication that you're needing to give them throughout this process. So if you can make them slightly more comfortable before getting that CT scan, I think it's better for patient experience.
Yes, so to reduce and manage the pain. Thank you. If we don't have any other comments, do we have any question, Gustavo or Lucian? Do you think? No, not for the moment. So maybe, please, Paula, you can go on a little.
Yeah. So this patient was a polytraumatized patient that came to the emergency room, and a resident asked for the images, right? Do we have a poll, or we continue?
Yes, I just shared a poll now about the therapeutic option. Which therapeutic option in emergency, please, if you can, for the attendees, if you can answer, between external fixation, close reduction and pinning, external fixation and deferred surgery. And Paula, you will ask the question, I think, later.
Yeah, just one more image. Under dynamic fluoroscopy, we can see a complete radiocarpal dislocation and reduction. It was very unstable with the radial stability. So now we can discuss the treatment options. So would you do a close reduction and immobilization with a cast, or
you can
external fixation or spanning plate even as a definitive treatment?
Paula? I think we
I think we lost her.
I think we lost her. Paula, do you hear us? Okay. Anyway, it's not a problem. So I will try to share her case. So here the case of Paula. Can you see my screen?
Yeah.
Okay, perfect. Paula, if you come back, please tell us. Maybe Rene, you would like to comment the case?
No problem.
Okay.
I have a comment, and I think that is the in the first moment when we have this type of patient, I think that the same comment on the same opinion of the Pedro is very important. The first treatment of this radiocarpal dislocation is reduction in the box in the operating room in the first moment. Yeah, is in the second part, the most important treatment is evaluate what is the complete damage of the radiocarpal dislocation, or damage of the ligament, or damage of the fragment in the distal radius or in the scaphoid, or a lot of injuries inside to the wrist. This is the first option. And in this patient, we have a trauma in motorcycle, and this is the one part of the damage. In the hand, we have a fracture in the base of the thumb, and fracture in the wrist, and we have a thoracic trauma and trauma in the brain. It's a polytrauma. Yeah. Ahlam?
Yes, you
the next slide. And
yes.
In this enter to the operating room, and 1 hour after the trauma in my clinic in 3 a.m. And my first evaluation in fluoroscopy is this is instability in the wrist. When I see I can see the reduction of the carpus in the when I put the traction and the lateral view on EP view, it's very good. And in this moment, I see the fragment of the stylet of the radius is in this position. The next slide, please.
You can see. Okay. You this slide.
Sorry, yeah, I disconnect myself. Yes. I can continue again. Sorry. It was the...
Yep. Okay, Paula, you continue, yeah, no problem.
So what I can do, Paula, I will stop sharing my screen, and you will go with your screen. Go on with your screen. It is okay for you?
Yes. Sorry, it was something with the, I don't know, the Wi-Fi.
Okay, perfect. Yes, perfect. So Rene was explaining how he managed in the emergency room the case.
Okay.
Okay. So So radiocarpal fracture dislocation is a rare injury, and most of the publications are case reports with few reports of serious in retrospective studies. And due to its rarity, treatment and outcomes are not well defined.
Sorry, Paula, I will do a round of our panelists to ask what they would do in this situation. If you can go back, please, to the situation in the operating room. Maybe I will ask, for example, Fabio or Marco or Mohd, who would like to give?
First, I would like to know about the condition of the patient. If the patient is a polytrauma, because the principle of treatment is a life before limb. If the patient is not stable for long operation, maybe I will do the simple procedure first, which is external cross-wrist external fixator for temporary immobilization before going to definitive fixation later if the patient is very unstable, especially in the case of polytrauma patient.
In the middle of the night.
Yeah, in the middle of the night. So maybe we don't have the expert available at that time also. So then later, yes?
Mohd, if it is what kind of fixation would you do in emergency, please?
I will use close manual reduction and external fixator first.
External fixator, okay.
Yeah, cross-wrist external fixator. Then I will do definitive fixation later because this patient also is a polytrauma patient. So I will use the damage control orthopedic approach. Then we need to fit the key fragment, which is dorsal ulnar fragment, which is a key fragment to prevent dorsal translocation of the carpus, and also radial stellate, which is important to prevent ulnar translation because there is a radial scaphoid ligament that hold the carpus and prevent ulnar translation.
Thank you, Mohd. So in a two-step of surgery, I totally agree. Politics of the damage control. Marco, Guidi, you wanted to add something maybe?
Yeah, I do agree with Mohd. I think we should always think about a damage control concept. Otherwise, we are doing something that it's not usable for the patient at the moment. We lose time. And Rene told us that this patient has already a trauma, so a thoracic trauma, maybe some other stuff that we don't know, a brain injury. So damage control first. So probably it would be an external fixator with reduction. And then after this window, so in a stability situation, we can discuss about the treatment. I think it would be an open treatment, and I would go for so double axis, so double approach for just to assess the ligaments. You can do as well, it's described as well, so with arthroscopy, but I think you can better manage as well the fixation because you need a plate for the radius.
What about the fracture, Marco or someone else?
So for the first metacarpal, I need just to see again, but probably it will be ORIF, so an open reduction internal fixation. If it's not possible, because I didn't look at the base of the first metacarpal, you can even do. There was described as well for multifragmentary fracture. You can do as well like a Suzuki frame. Eventually, you can adapt others pinning, but of course, an internal fixation with a plate could be better. But of course, you need to assess the multifragmentation of the base of the first metacarpal. Then you have a sided fracture. It was very nice showed by Rene during the movements that you need to fix it. I think it's more or less one block. So you can try if you don't have. It depends on the material that you have. You can start with pinning, and then you can put a plate from lateral. And then you need to assess the volar and the dorsal ligaments, of course. As Francesca said, this avulsion fracture from scaphoid can be so SL ligament injury. So you need as well to assess that. But as I told you, I would do a double approach. Probably in this case, I would not do arthroscopic reduction.
So for Marco Guidi, double access volar and dorsal and repair of the radiocarpal ligaments, as I can understand. So we will see what will be the therapeutic choice by the authors. I can see Francesca or Zé has something to add. Zé, please.
Yes, I totally agree with the sort of damage control thing, but personally, I mean, I just want to see what are the panelists' thoughts about it. But personally, I find that acute injuries tend to be it's easier to actually repair them. And so like in this case, I mean, personally, I would actually repair and fix the radial styloid fracture with probably a Hiller's compression screw if it's big enough. And also probably do an arthroscopic assisted to assess the volar ligaments, and perhaps I have to actually do a suture anchor or some form of a fracture fixation to the distal radius, but I need to see the X-ray and CT scan properly. But what are your thoughts about actually fixing the fractures and ligaments acutely, combination with external fixator?
You mean using the external fixator to secure the osteosynthesis? Yes.
Yeah, what I would do is probably do acute repair of the ligaments and fixation, and a combination of external fixator for first stage. And then the second stage, you can probably remove the external fixator rather than the other way around, where you do external fixator first and fix secondarily. But this is what I would do, but just want to see what are the panelists' thoughts about it. Thanks.
Yes, I totally agree. The discussion is to fix and the fracture to stabilize the radiocarpal structures, and after to secure this reduction either by external fixator or a cast, for example. I would personally choose a cast instead of the external fixator because there are many soft tissues injuries that are associated, but it is my choice. Any other panelists who would like to add something, please? Francesca, before we go on.
You know, I agree with Zé. I would probably, as a definitive treatment, if of course medical conditions are favorable, I could put the recent traction, repair the styloid fracture, yeah, with like a screw. So already you have the radial side because the ligaments are not torn. So you already like fix the ligaments. Then I would probably repair the scapholunate injury, and then depending on the damage on the extrinsic ligaments, probably it would be necessary either an X-fix or a spanning plate to then remove afterwards.
Thank you, Francesca, for your comments. I would like just to ask Paula and Rene, what about the neurologic assessment? Because it was a close...
Yeah, just remember that this was a polytraumatized patient. It was at 2 in the morning, right? And about the last comment, if you do like a damage control surgery, you can still go back after 3-4 days, and that would be still an acute repair, right, of the ligaments. Like so I think that for me it doesn't make a difference between 3 days or 4 days, and it do make a difference to go and operate at 8 in the morning than 2 in the morning. Right.
And Paula,
totally agree.
For Rene, totally agrees with Paula. It's a good thing. Yes.
The problem is I think that is the damage control is our concern. Yeah, I think that is when we have a radiocarpal dislocation and luxation of the wrist. In this moment, I think that stabilization of the wrist and evaluate what is the real injuries in the carpal. This is my first option, and the second part, I want to treat for Paula told us 4 or 5 days when I have very clear what is the injuries in the radiocarpal, the extrinsic and volar or dorsal. Depends what is the damage, what ligament inside to the wrist damage. This is my main objective.
Thank you, Rene. I totally agree. In the middle of the night, we have usually the carpus, the hand is really secondary for the anesthesiologist, for everyone and for the patient. Pedro, would you like to make a comment on this, please? We can hear you, Pedro.
Yeah. In my opinion, there are 2 different scenarios. The first one is the polytrauma. You know, you have a protocol, ABCD. D is for the orthopedic trauma surgeons, and probably hand surgeons is the last part of this E. In the other part, we need to discuss what is exactly what is the perfect treatment for this type of fracture, independently of the type of patient, because it's so different. Because probably you have a polytrauma patient, the most important is the fracture of the chest, fracture of the femur, fracture of the tibia, but probably the hand is the last part normally. In this case, probably external fixation is fine with a keywords, no more. But in my opinion, I agree with Rene that the most important is what exactly the perfect treatment for this type of fracture. Probably to restore the anatomy with using, for me, mini-invasive technique. You may restore the anatomy, restore the ligaments. You can check the chondral injury, and probably so different for in the global patient. Probably you have only this type of fracture, and you can delay the treatment for 3, 4, 5 days. Is perfect to treat with a mini-invasive surgery. As this is my opinion. But is the other part, if you have a polytrauma patient with a huge trauma, probably in this case, only a sena fixation or a fixation with a keyword is enough. But the question is, what you do if you have a patient, the patient is stabilized, you only need to treat only the wrist. Probably for me, the fight one, the closer action of fixation with arthroscopic system. This is my opinion.
Thank you so much, Pedro. I would like to share just the results of the polls. 15% choose the close reduction and percutaneous pinning as definitive treatment. 25% external fixation and deferred surgery. So the majority agreed with us. 25% open reduction and fixation with ligamentous repair in the emergency. And 35%, the majority, close reduction and fixation with arthroscopic assistance in emergency. So it is very interesting. And now, Paula, I think you can tell us what you did, please.
Yeah, so as I said, this is a rare lesion. In this review, Dr. Kakar concludes that the most frequent injury mechanism is a wrist hyperextension plus a forearm supination and an intracarpal pronation. The volar radiocarpal ligaments avoid the ulnar translation of the carpus, and the vast majority of the current evidence are case report, and most of these have short-term follow-up. So in this review, they analyzed 26 patients between 1979 and 2010. The average age was 39 years, and almost 90% of the patients were male. 1 out of 26 patients presented volar dislocation, and 65% of them had an associated distal radius fracture. 8 patients went under fixation in the first surgery. 23% of the patient went under percutaneous pinning only, and 3 patients had a primary bone fusion because of a great cartilage damage. So this table refers to the 13 patients who went under primary ligament repair, almost all of them with double approach, and 5 of them were lost in the follow-up. As for the relationship between the type of surgery performed and the functional outcomes, we can see that the patient that who underwent a primary ligament repair had better scores compared to the ones that underwent a primary arthrodesis. Mohd proposed a classification in 2 groups, where group 1 are patients without intracarpal lesions, and group 2 are patients with intracarpal lesions. Dumontier in 2001 proposed a classification with 2 types to help guide the treatment. Type 1 is a pure radiocarpal dislocation, or a fracture dislocation associated with a fracture of the tip of the radiostyloid. And type 2 is a fracture dislocation detaching a larger fragment. So for these cases, type 1 requires a volar ligament repair and K-wires for at least 2 months, and type 2 requires an anatomical reduction and fixation of the bone fragment. So the viable classification are helpful, but seems to be incomplete in terms of description of associated lesions with a prognostic importance, such as a distal radial nerve involvement and marginal fractures. So currently, new classification systems have been proposed, which try to combine and complete the already existing ones, right? This latest publication of an Australian group proposes a treatment algorithm depending on the type of injury. So back to our case, fixation of the radial stylo recovers the wrist stability, as you can see in the video. It is important to remember the stabilizing extrinsic ligaments of the wrist and their insertions, the dorsal one, and especially the volar radiocarpal ligaments, who play an important role in this type of injuries. In this case, we make sure to also recover the dorsal stability of the wrist. As you can see in the video. And based on this paper, radial styloid pinning is sufficient and a surgical approach is not always needed. Thus, palmar repair does not appear to be necessary. As an emergency surgery at 2 a.m. In the morning, we perform a transitory fixation with K-wires, as you can see. And now, 4 days later, from a 6R radiocarpal view, we assess the radial styloid fracture, and we can see a torn scapholunate ligament. Can be seen in the video. This is another video of showing the scapholunate ligament lesion and the styloid fracture. So under arthroscopic assistance, we perform the radiostyloid fracture fixation with the help of K-wires, making sure we achieve anatomical reduction of the scaphoid fossa, placing a headless compression screw. From a mid-carpal view, we confirm a complete scapholunate tear, as you can see in this video, and I think in the next one as well. So we see the volar part is torn, the middle part and the dorsal, corresponding to a reducible type 3C in the Iwc arthroscopic classification. And unstable scapholunate interval. On the other hand, we found an intact lunotriquetral ligament, which was competent, right? So in summary, we have a radiocarpal dislocation type 2 plus a scapholunate lesion, Iwc type 3C, Geisler 3.
Sorry, Paula. For this, I will just share the new poll. What is for the attendees, please, the management of the associated scapholunate instability. We have an AWAS 3C here. Would you perform scapholunate pinning? Would you do a scapholunate screwing? Or arthroscopic dorsal capsuloligamentos repair? Or ligamentoplasty reconstruction here? So please, if you can answer the polls, I will show the results after. Thank you. You can go on, Paula, please. Thank you.
Okay, so we decide transitory reduction and association of the scaphoid and lunate, the so-called RASL, not as a definitive treatment, of course. This was performed all percutaneous, minimally invasive technique, allowing an early mobilization in order to prevent wrist stiffness. So we can see that the wrist is stabilized after the surgery. And this is the coronal view after all the surgery. The scapholunate interval post-fixation, you can see that it's stable now. These are the post-op X-rays. For the thumb, there was no involvement of the articular surface, so it was also pinning with the K-wires. And 6 months post-op, we do a second look and screw removal with arthroscopic assistance. So we first took out the screw, as you can see in the video. Second look after 6 months, we can see the difference. The scapholunate ligament has healed. This is the final X-ray after the screw removal. And as you can see, the metacarpal has also healed. This is the other view. And very good functional outcomes as well. So radiocarpal dislocations are rare, complex injuries and not easy to manage. They occur frequently in young and active patients as a result of high energy trauma. Accurate classification leads to a surgical treatment strategy. Consider always bone, ligaments, and intracarpal lesions. With adequate treatment, good, even long-term functional results are possible. And arthroscopic assistance is useful and a game-changing tool. Thank you.
Thank you so much, Paula, for this beautiful case. As usually, beautiful results. Congratulations, Rene, as well. Thank you. Do we have any question, Lucian or Gustavo, in the chat, please, from the attendees?
Hello, everybody.
Hi,
Sorry
Lucian.
to be late. Carlos Hackett is only saying that it was a great case and gives Rene and all the team the compliments.
Thank you. Just sorry, Rene and Paula, you didn't answer my question before. If in this kind of case you have in the acute situation in the emergency room some neurologic deficits, what would you do in the acute situation in the emergency room when it is a close dislocation, or median nerve, for example?
Yeah, you register that in the clinic, story of the patient, and then you release the carpal tunnel.
If it is a close injury, dislocation, you choose to systematically release the carpal tunnel in the acute cases? Okay.
If they have symptoms.
Okay, if you have symptoms. Okay. Everyone agrees because
if they persist after close reduction, then you perform the carpal tunnel release.
Yeah.
Okay, thank you. I agree, because sometimes there is a discussion about the actinogenesis of the nerve that heals if he waits. But I agree. In the acute cases, I would release the carpal tunnel. I can see Zay would like to comment.
Yes, thank you so much for the case. It was a very good case. Congratulations. But I've always been very curious about the removal of the Russell screw. Is it easy to remove a Russell screw at 6 months post-op? And what is your trick in removing the screw?
It's not easy. We have 3 or 4 patients when we have removed the Russell screw, and we have describe a technique in this moment. When we have in the arthroscopic view for the radiocarpal view and 1 and 2 and 2, 4 radiocarpal view, put in the first moment I put the screw and the head of the screw minimal view in the zone of the cartilage. Okay, I leave intentionally in this zone. Okay, when I evaluated 6 months after of the first surgery, when I put my optical in the 1 and 2 and 3, 4, I can see of the minimal part of the head of the screw. This is the first. I use this shaver in the zone. I clean in the head of the screw. I put the key wire of the cannulate screw, key wire, and pass the key wire to the scaphoid, lunate, and the left side of the wrist in the TFCC. Yeah, and this one put another drill is the top, another drill, and put the extract to the screw on the right side. You understand me? Put in the right side and the left side, one drill, and extract to the screw. In this moment, I can remove the screw. The screw 6 months after the surgery is not hard. It's very difficult to extract the screw, move inside to the scaphoid and lunate. It's not hard. The extraction is very difficult. Okay, this is my technique. Put the extractor to the screw and put another drill in the left side.
Thank you.
Thank you, Rene, for this answer. Just before Pedro, I would like to share the results of the polls. 30% of the attendees would have done a scapholunate pinning for the scapholunate instability. 10% scapholunate screwing, temporary fusion. 45% of the attendees arthroscopic dorsal capsular ligamentous repair, and only 15% for the ligamentoplasty. So thank you everyone for answering the polls. Pedro, you would like to add a comment, please?
Yes, the first one is congrats for Rene and Paula, because it's an amazing case with a good treatment and excellent outcome. But my question is for Paula and Rene. Do you think that it's possible in this case to treat only with dorsal capsular disease associated via arthroscopy, with or without the Russell technique?
Yes. We have a several options. It's a very good question of the Pedro. in entrance to the arthroscopic, I don't know what is the real injuries, what ligament injury. You can see in the mid-carpal arthroscopic view, we see of the fragment in the lunate, Pedro. Can you see of the fragment in the lunate? This is the insertion of the radial lunate and the large radial lunate, probably, right? And when I prove in the volar part of the scapholunate, is the open is minimal hard, and the dorsal part, the tear is when open is easy. Okay, I think that is capsuloplasty, and keywise. When in this moment, I think that when I put up the screw, I think that is a hard construction of the stability in this moment. We need when in the previous part of the surgery, I put the screw in the distal radial part and stabilization of the radiocarpal joint. In the second part, I told me I put the screw in the scaphoid and lunate. I eliminate in this moment eliminate all the percutaneous pinnings in this zone. And in the second part, when I put the screw of the scapholunate joint, I repair with the capsuloplasty dorsal part of the dorsal carpal interligament and scapholunate in dorsal part. Associate the stabilization and capsuloplasty in the dorsal part.
Yeah,
Paula,
thank you for Dr. Delgado. Like, if you perform a dorsal capsuloplasty, would you always protect your suture with K-wires, or would you trust your suture and not put a K-wire?
It depends, because in this case, it's an acute case. It's so different for a subacute or chronic case. For a subacute or acute cases, I don't use any K-wires because I prefer to perform with anchor fixation. But for chronic cases that you create a new wound, in this case, it's mandatory to perform with fixation with K-wires or something like this.
Thank you, Pedro. I agree with Pedro in the acute cases. We first restore the anatomy with the anatomical reduction and osteosynthesis. So for me, the arthroscopic dorsal capsular ligamentous repair is enough because we already restored the anatomy. So the acute cases are little different from the chronic cases. Do we have any other questions and comments?
I have a little big comment in the finish. In my country, when I presented this case, the main discussion is the volar approach of the repairing the extrinsic ligament. It's a discussion when arthroscopic non-believers, arthroscopic non-believers in my country. Pedro know what is my arthroscopic, and no, volar approach of the extrinsic ligament repair. We need a stabilization of the radius and repair in the volar part and dorsal part. No arthroscopic, no minimal invasive, no percutaneous, no. Open. A lot of people in my country open this case. Is a very good option. I think that is very good option, and I think that in this case and another case in another country, I think that is very good. Analyze what is the real injuries in the ligament. When in this option, repair or stabilization the joint, what the depends of this ligament. This is my opinion. We don't need always open the dorsal part, open the volar part. Depends what injuries we have in this moment. This is my opinion, personal opinion. I think that Pedro's opinion and Gustavo's opinion the same. When you see inside to the arthroscopic view in the radiocarpal and midcarpal, we see all ligaments. You understand in this moment what is the best option of the treatment?
Thank you, Rene. Gustavo, we wanted to add something before.
Oh, well, everything it has said. I didn't want to interrupt you and delay the discussion because we have now a new case where I'm going to talk a lot. But I think that it's very important to understand the mechanism of the injury, as Rene said, because that is what is going to give us a plan and to tell us which ligament must be treated. And I think that is the most important thing, to understand the pattern of this radiocarpal dislocation.
And I think the radial styloid fracture is very important in this case because you have big fragments of fractures. And you know, the main radiocarpal ligament insert here. It's strong fixation. It is enough. We can check it under arthroscopy. And I think open approach is not the best option in this case. Thank you,
Exactly.
Rene and Paula, for this beautiful case. We saw that the damage control was very important in this case of polytrauma, and also the arthroscopic assistance treatment, secondary treatment was very useful here in this type 1 Dumontier type 1 injury. So I think we can, if we don't have any other question, we can move to Noelia and Gustavo case, the central depression in distal radius fracture, the arthroscopic treatment. Noelia, do you hear us? Could you please share your screen? Thank you.
This is a simple case. It's not a complex case, but it's just because we want to. I think it's very important to review some basic concepts. So now Noelia is going to show us the case.
Thank you.
So good morning to everyone. Thanks for the opportunity to present. So we start with our case. We present a 32-year-old male office worker. He plays football as a hobby once a week, and he suffered after from a wrist trauma after 3 days. We present these X-rays where we can see an AP view and a lateral view of his wrist. So on the X-rays, on the AP view, we can see that there is an alteration on the articular line, especially on the scaphoid facet, on the proximal pole. And on the lateral view, we can especially see that there is an increase on the width of the radial distance and carpal subluxation molarly.
So to start, I would like to ask to Pedro, Rene, to Seth, and to everybody. I see Leonardo Lazaro is too here. Do you always order a CT scan in these cases, or sometimes you order it's important for you to have an MRI?
No, I choose a CT scan always for a case like this.
Totally agree. The same.
Yeah, same here.
Me too. Me too.
Me too.
Faster and cheaper.
Somebody order an MRI or somebody goes to decide the treatment of this patient without a CT scan?
I think, Gustavo, we all have the access to the CT scan, but I think in some countries or in some places, they don't have an easy access to the CT scan in emergency. So we should not forget that we need to do without CT scan and go back to the basis in some places.
Exactly.
Pedro?
Gustavo, really is only 3 days of after the injury, because the aspect of the bone is a little bit with a lot of osteoporosis. Porosis with ulnar deviation of the carpus. It seems not a acute trauma. I don't know if it's true or not.
Okay, yeah, it's an acute injury. I received this patient in the office. Yeah, but I see what you're saying. The radial styloid seems a little bit rare there. Carlos, you are there. We cannot hear you, Carlos.
Carlos?
Can you hear me?
Yes.
Yes.
I'm totally agree with Ahlam. If I have CT scan in my center, I will indicate a CT scan. But if I don't have CT scan, I will proceed to the surgical procedure just with the X-ray. The CT scan didn't stop me to treat this fracture.
Do you have, Carlos, as you don't have, if you don't have a CT scan, do you have any comments how we can interpret this X-ray? Do you have any landmarks, something to help us?
Yes. Mainly the dislocation, subluxation of the carpal bones that could give me a lot of information about the gravity, the
severity,
the grade of this injury. The images that I can see only in the X-ray in the scaphoid fossa. I think that in this specific case, not having CT scan could be enough for me to decide my management of this case.
Thank you. Lucian, you wanted to say something?
Yeah, actually, I think those cases are the most important ones to study with CT scan, because you see only the fossa. In the AP view, you can see that the articular surface is not continuous in the fossa of the scaphoid, but you don't know the extension and how big are the fragments. And if you are not doing the surgery with arthroscopy, it's very dangerous not to do it without a CT scan, I think, as the majority doesn't do it with arthroscopy. This is one of the most mandatory cases of CT scan in my personal experience, because you need to know how much extension there is, for how many fragments are there, how big is the extension. How can you fix these fragments? Can you fix them with a screw? Are they big enough? What is the method you need to use in open surgery to reduce them? It's not so simple. With arthroscopy, if you are experienced arthroscopy, it's easier. In open surgery, it's much more dedicated to achieve a good result, I think.
Great. Thank you, Lucian. So the thing is that we are against a distal radius fracture, which has a rare scaphoid facet on the radius, but we cannot see the real magnitude of the injury with the X-ray. So we order CT scan. Okay, can you continue, Noelia?
Yes. So as we agree all. So we ask for a CT scan. These are the sagittal views, where we see a central depressed fragment, as well as well as the affection of the volar cortex, okay, and a volar subluxation of the carpus. So on the coronal view, again, the central fragment involving the scaphoid facet, as we mentioned before. And at the actual view, there's the same, we see the central fragment. So I think it is important to always, as we just mentioned, that we use all the planes to perfectly identify where these kind of fragments are, especially if we don't have arthroscopy. So this is our case, intraoperative images, where we identify the dorsal fragment, the central depressed fragment, I cannot continue because of the questions.
Noelia, in between, I will ask the attendees to answer the polls. And this is the last poll for today. What would be your treatment strategy in such a case, please, for arthroscopic reduction, then fixation? You have the choice of open reduction and fixation, then arthroscopy. You have the option of proximal fixation, then arthroscopic reduction, and you have the choice of open reduction and fixation. And the last option is the external fixator. You can go on, please, Noelia.
I have the questions, so I cannot continue. Won't let me.
What do you have, Noelia? Please, I don't hear you.
The rotation, the treatment options.
Yes.
When you have questions,
you need to click on.
You won't let me continue.
Yes, you can go. You can go on.
But I cannot see.
Okay. Okay, so we would like to discuss now how you will approach this case in the operating room. What will be the steps to follow regarding when to place the plate, when to do the arthroscopy, when to fix the proximal screw and the distal screw, because many times we talk about operating this kind of fracture with arthroscopic assistance, but we don't talk about how to do it step by step during the surgery. So I would like to start to see your opinion in what moment you put a plate or do the arthroscopy. You start with arthroscopy, you start with the plate and proximal fixation.
Someone would like to answer. Lucian, I think in the discussion there is Christophe Matulin that can't speak because he's in a restaurant. He joined us. Hello, Christophe. Could you share the discussion, please, Lucian?
So Christophe said, I think tendinous interposition could be an option. Even in acute case, reduction first, and we see after reduction what's happened. But I think that the cartilage is damaged. So this is what he said. And then he, after seeing the X-rays, the last X-rays, effectively after the lateral X-rays, maybe arthroscopic reduction and volar plating and second look. So he is more now, after seeing the last images, on arthroscopic reduction and volar plating as an treatment option.
Thank you. Thank you, Christophe. Thank you, Lucian. We have also Fabio and Zé. Fabio, you would like to say something? I haven't heard you before.
Hello. In my opinion, this is no easy case. In some central depression, I believe we can reduce fix with a screw. only, but in this case, fracture is complex. I prefer use a plate because I need to reduce the depression and reduce the fracture in the volar side. In this case, I prefer open approach to put the plate only with the K wires, then perform the arthroscopy to reduce the depression, and probably use, depend of the situation, some K wires to fix the depression, and then put the screw throughout the plate. But this case is not easy.
Thank you. Thank you, Fabio. Noelia, could you go back to the CT scan, please, so we can comment with the images, if you don't mind.
Excuse me, Ahlam. I have a comment to what Fabio said. You can put the plate on before a reduction of the central fragment if your plate has a central window, which permits you to reduce the fragment. If your plate doesn't have a central space or window, you will need to reduce first the central fragment. Otherwise, you cannot do it afterwards, in my opinion.
Okay, thank you. We have Zay. You wanted to add something before?
Oh yes, I was just thinking about how I would fix this. So in terms of the if you allow me to share, but in terms of the step-by-step, I will go through a volar approach for this case. So volar approach through the either modified Henry down to the bone itself, and I would place the preliminary plate fixation first with a cortical shaft screw. So the cortical shaft screw in the oblong hole will allow the plate to sort of slide distally or proximally whenever. So I will place the cortical shaft screw plate first, but prior to that, I would try to attempt reduction. So in this case, it looks like from the CT scan, there is a volar ulnar fragment that is fractured. And like what Dr. Lucian say as well, you need to have a window at the front to try to reduce the central depression. So I try to sort of extend the wrist and try to look for a cortical window at the front cortex, try to use a wire or a freer elevator to try to elevate the fragment. And also I would try to attempt to put some artificial bone graft or some sort of bone graft to try to support the central depression. And then I would reduce the cortex, put on the plate with the cortical shaft screw. And most importantly to me, the cortex must be aligned very well, and also be sure to catch the volar ulnar fragment. Once the cortical screw is there, I would put a Mohd ulnar distal screw to sort of stabilize the volar ulnar fragment first. And then I will put in a scope. So I'll put the patient then on traction, I'll put in a scope, and I'll try to check the central depression. And I would put some joystick wires volarly to try and see whether if I could joystick that. I feel that personally the joystick wires is to fine-tune the reduction, but it doesn't really help you with the main reduction. So that's my thought process. And after we put joystick wires to try to fine-tune and try to reduce the articular fragment, then I would put in the rest of the distal row screws under arthroscopic guidance.
Thank you, Zay. Thank you. So we have some opinions. Anyone else would like to comment? I think you can see Fabio, Marco, Pedro. Tadeusz wants to say something, and maybe Pedro after.
Okay, I totally agree with Z. Thank you for your thoughts. I think I wouldn't go for just bone graft anything. We can secure it with the central part with key wire for a while as a joystick. And then there are multiple screws, so we can secure it with the distal and second distal row screw. That's it. And the rest, I totally agree with you, Z.
Thank you, Tadeusz. Pedro, you would like to add something, please?
No, because I very agree with all the speakers, but probably in this case, for me, the first one is to perform arthroscopy to assess and to show exactly what is the fragment, the pressure, etc. Second one, remove the traction, try to reduce the fracture with an open approach, with a volar open approach, with a medial window, because it's so important to access to this. And then probably during arthroscopy, we try before to redact a fragment, especially the central fragment. And then probably in this case, I try to add some bone grafting. And for this case, probably is the most indicated case to treat with a specific fragment plate. Probably in this case, it's not important to treat the fracture, it's to treat the fragments. Because, you know, many in this case, you have the ligament attachment and you don't need a big plate, probably a small plate, a specific plate to treat probably the two fragments, the volar fragment of the radius and also the part of the sigmoid notch of the ulna. But probably Gustavo shows to us the perfect treatment for this case.
Thank you, everyone, for the comments. Gustavo, you would and Noelia, you would like to go on with the case? Show us.
So this is animation of our fracture to simplify and better understand what we have been saying and do the actual step by step. So we have our central fragment. If we proceed as usual by placing the plate volarly and fixing it with the volar screw, the problem is that our central fragment gets encapsulated and it will be risky and almost impossible to rotate it, lift it, or remove it. And we take the risk by actual breaking it, and they are already small fragments. So it turns out to be actually a headache for us surgeons. So we think it is better to first place the plate by a volar approach, as we regularly do. We think it should be placed first key wire temporarily, volarly. What we have to take into account that is very important here to present the plate where it will be the final position, just proximal to the watershed line, because it will be where we will fix it later without taking anything. So now we proceed with the arthroscopy using a 6R portal for the scope and the 3-4 portal for the probe, which will we use as a hook to disimpact and reduce all the central fragments. And also to hold it while the assistant places the proximal cortex screw and presses it through the cortex against the cortex to restore all the articular surface. Only then, when we see that we have an anatomic reduction, we proceed to place the distal locking screws. In our case, these are interpretive images.
Sorry, Daria. I want to make a comment. We show the animation because we want to highlight that, as said and Pedro comments too, it's very important to try to disimpact and to reduce a little bit the central fragment before start to compress the plate against the volar cortex, because otherwise, as Noelia said, these fragments sometimes keeps encapsulated inside the epiphysis of the radius, and when we are doing the arthroscopy, it's very difficult to disimpact these fragments, and we start to do some maneuvers that make a new fracture of these fragments. So it's just to review some step by step that we are that we do very often in the operating room. Now Noelia is going to show the video of the arthroscopy and the image intensifier images.
So here is our plate with a temporary fixation with the key wire. We can alternatively use 2 key wires to avoid rotation of the plate. And we see that we have placed the cortex screw, but without trespassing the dorsal cortex, and without placing or actually the plate. So here is our dorsal fragment, our depressed fragment, and the volar fragment. So only after that we proceed with the arthroscopy. The first step, as usual, will be washing and removing all the hematoma from the surface. You can see in the video. And then the next step will be identify our fragments, the volar fragment, the central fragment, the dorsal fragment, and the styloid. And we use the probe to scratch between these fragments to remove all the hematoma we have said, and to release them the best we can without breaking them, and washing again as many times as we need. So once we have released the fragments and reduced them using the probe as a hook to elevate, depress, or rotate the fragments however we need it, we are reducing fragments. Sometimes we can also use the volar approach to push from below these fragments that might be very impacted on the breast. So we then, once we have reduced all the fragments, we hold them with the same hook, and we ask the system to fix the plate and press it to reduce the volar facet while reducing the carpal subluxation as well. So here we appreciate the articular surface reduction after placing the plate, and after definite fixation of the distal screws on the APL lateral view. And we also use oblique images, impronation and supination that serve to double check the joint surface reduction. And after our final fixation, we recheck the stability of the fragments by touching them and pressing them to make sure they are stable enough and we won't lose our reduction on the post-op. So these are post-operative X-ray images, APU and lateral view, that, as we all have said before, that we believe that the best way to check these small fragments and to do a better follow-up with our patients, we use CT scans. We think that they're better than X-rays, as it all permits not only to better understand the fragment, but actually see these small fragments reduction, especially the subchondral screws that sustain them. This is the coronal view that we can perfectly see all the screw and to avoid collapse of the small fragment after surgery. And
okay, before continuing, Noelia, sorry, Christophe Matulan, Professor Christophe Matulan is asking to Pedro. He said, in my experience, grafting was not necessary. Why do you use it? And where do you place the graft? Volarly before the plate?
Yes, I don't like to use bone grafting normally during my practice with a reduction of the distal radial fracture. But in many cases, you have a small fragment with a huge of the fat or under the subchondral bone. In this case, the bone grafting allows to you to have a big fixation and also an easier fixation, which you have a great base to put this type of fragment. It's only in a few cases. And of course, I put it only in these cases, of course, before plating, because I think it allows to you to have a good reduction, but it's not mandatory, of course. It's especially in older men, you know.
Thank you, Pedro.
One question, Gustavo, for you.
Yeah. Yes.
Do you think that another type of plates, like specific fragment plates, will be used in these cases, or it's not necessary?
No, yeah. Well, I think that any plate that allows us to go with the screw to the subchondral bone of this kind of central depressive fragment is okay. But I think in this case, it was enough with this kind of plate, but you can use a radial column plate, for example, because this was a fragment of the radial column because it was in the scaphoid facet, but it is not always necessary to use a specific plate fragments. In this case, we use just the standard plate, the volar locking plate, standard plate. And I prefer to use this kind of plate because if you see in this image that is showing the CT scan on the lateral view, you can see that there is a compromise not only of the radial column, but also of the ulnar column. So we have to go with the screws to both columns. So sometimes with specific fragments plates, you have to use a plate for the radial column and another plate for the ulnar column. And in this case, I think that just the standard plate was enough to take and fix both columns.
Okay, thank you.
Thank you. Okay, now you want to continue, Noelia, so we can go on with the rest of the discussion?
So this is the actual view to check also the length and the distal radio-ulnar joint reduction, and pre-op and post-op CT scan with the central fragment reduction. Same as on the coronal view with the central fragment. And so after reviewing a few things on the literature, we can say that the most important thing when operating a distal radius fracture, especially with arthroscopy, is to restore the normal angles, the volar tilt, the ulnar variance, and the radial inclination. And also knowing that arthroscopy is especially useful to restore gaps, articular step-offs, and to diagnose and treat when necessary associated injuries. And so the recommended step-by-step that we use at least when doing a radius distal fracture guided by arthroscopy is first do our regular volar approach, the open reduction partially without completely pushing the plate towards the cortex, with a temporarily proximal fixation with key wires, either one or two, to avoid compression and the imprisonment of these fragments, central fragments, as we cannot reduce them after, because since they are not attached to any ligaments, we cannot reduce them by ligament ataxis. Then we proceed to the arthroscopy reduction, and finally the distal fixation with locking screws. So when we talk about central depressions, we have to take into account that they can affect either the scaphoid facet or the lunate facet. And this is another case with a central depression and carpal subluxation of the scaphoid facet. We can see the initial reduction that has been done, that it might seem appropriate or maybe accepted, but we can see that they have put the plate, positioned the plate and the proximal screw. But then when we go to the arthroscopy, we can see a completely rotated fragment, and only then. So this is how useful the arthroscopy is, that we can really look and see that we have achieved an anatomic reduction for sure of the joint. The final fixation of the intraoperative, and before and after CT scans, the fixed central fragment, the lunar facet fixed, and a coronal view, and the central fragment fixed as well with a subchondral screw. And in these kind of fractures, we can we think and believe that CT scans are better on the postoperative follow-up to check, especially these kind of screws and subchondral screws that we use. In this case, it's an affection of the lunar facet, where on the X-rays we might think that there's maybe an acceptable reduction, and maybe some people would treat it as a conservative treatment, even though we can actually see that there is an affection of the joint and the articular surface on the X-rays. So when we see the CT scan, we have a central depressed fragment, as well as an articular big step off that at least 3-4 millimeters, and sometimes don't seem so evident on X-rays. So the sagittal, all the views, the step off. And how we proceed to, as we have said before, by placing the plate with the key wires first, the video intraoperative, where we see completely rotated fragments that we have to de-rotate almost 180 degrees and disimpact them. That's complete rotated, that we use twitzers to rotate. And fix it. And after the reduction, we recheck all the fixation and the stability of each fragment with the probe, as we have said before and showed on the previous cases. Postoperative X-rays, CT scans before and after on the coronal view, the sagittal view, and axial views. And in conclusion, we have to always remember that the most important, it will be always to try and restore normal angles of the distal radius as well as the anatomy, identify in all the planes the fracture pattern and its fragments. And for that, we think the CT scans are the best ways, not only pre-op but post-operatively, to do the follow-up. We have to consider in these kind of fractures that arthroscopy might be a really good method that allows us to elevate, depress, and rotate fragments, but especially treat central depressions that cannot be reduced by ligament ataxis. And stabilization with subchondral screws, and double checking by arthroscopy are essential to avoid collapse after surgery on the follow-up. So thank you very much.
Thank you, Noelia. Sorry.
There is a question from the chat of Marco Guidi to Gustavo. Marco asks if you check as well the DRUJ in arthroscopy in order to check the reduction of the sigmoid notch.
Well, it's very uncommon, but sometimes we have to do it. It's very rare because we have, as Noelia said, we have to identify the fracture pattern. I think that one of the most important view that most people have no importance is the actual view of the CT scan. In the actual view of the CT scan, we understand the morphology of the fragment, the shape of the fragments, and we can see if there is a step off on the sigmoid notch of the radius. If under arthroscopy, I have a nice view, a nice reduction, an anatomic, and I'm sure that I'm having an anatomic reduction of the articular surface of the radius. So I think that is an indirect way to know and to see that the sigmoid notch may be with a good reduction too. But if I cannot achieve a good reduction of the articular surface of the radius because I have a great convolution, perhaps in this case that I know that I have different fragments in the sigmoid notch, perhaps in this case, but I repeat, it's very uncommon. I go to the proximal, to the distal radial ulnar joint portals to see the sigmoid notch. But if I have an anatomic reduction of the articular surface, I know and I'm sure that the sigmoid notch is okay too. I think that these fragments are very important and we must be careful because under image intensifier, sometimes, as Noelia said, the peripheral fragments give us a false image. So if we go to arthroscopy, when we introduce the scope, we can see the reality and sometimes these fragments are very displaced. Therefore, we must reduce them before definitive fixation.
Yeah, I think Gustavo, in this audience, you convinced everybody. The problem we have is to convince the others in other congresses. This is the main problem we have.
We have actually, sorry, Lucian. I think we have a question from the chat, not from the chat, from the attendees. We have Marcio Aita. What do you think about volar capsule suture in plate to improve stabilization or avoid secondary dislocation?
Sorry. Now I think a question. What do you think about volar capsule suture in plate, improve stabilization? Well, I don't do it as a protocol in all patients, but if you have some radiocarpal instability and after you perform the arthroscopy, you can see, you always see when you have a torn of the radiocarpal ligaments, you see like a little bit of avulsion of those ligaments from the cartilage of the radius. If I see that I have this kind of injury on the volar radiocarpal ligaments and I have some instability, well, I think that it's a very good idea to suture the volar capsule to the plate. You can use some anchors too, but this is a very, very, very easy way to solve the problem.
Thank you, Gustavo and Noelia, for this great case. We understood the chronology of the steps. It's very important between the reduction of the depression and the stabilization with the plate. Do we have any other comments from the panelists, please?
I want to address Gustavo if he uses also tools from focally from the fracture, metaphysics tools like Volkmann or something like this to decompress the fragments.
Yeah, we can sometimes perform a window on the volar cortex or just through the fracture, we can introduce the tool that you prefer to push the fragments from below. It's a very easy way to disimpact the fragments. And during arthroscopy, you can see, as Noelia showed it, that those fragments start to release, and you will be able to reduce them more easy if you do it just with the hook, with the probe. It's a nice idea to release the fragments.
Other option, Gustavo, is in the joint, use a free with different angles and some osteotomes to remove the central depression or the fragment in the middle of the joint. It's very important go around the fragment with the free and or osteotomy to release the fragment, and then use the hook. But if the fragment is big, I go your recommendation, open the window in the volar side, and then use some element to up the fragment. And then it's very important, the screw is very subchondral, it's very important. And after they put the screw, I use the hook to press the fragment, if the fragment depressed or not.
Do you have sometimes in your experience, Gustavo, or someone else to put pins instead of screws because of the screws are too big? Do you have any problem with the diameter of the screws sometimes in subchondral fragments?
Well, sometimes the fragments are too small, so it's very difficult to fix them with a screw. So sometimes we have to use a key wire. It's very rare and uncommon, but sometimes those fragments are very small, and the screw cannot catch them. But one of the idea that we want to say is that if you cannot fix those fragments, at least you have to do like a floor with the screws in the subchondral bones. So if you can fix those fragments, at least that fragment cannot collapse after the surgery. So that's why Noelia gave importance to put the screw on the subchondral bone to avoid the collapse of the fragment. Indeed, if we weren't able to catch them, to fix them.
Do you mean sometimes the small fragments are auto-stable, and because sometimes they look like they are not auto-stable if we leave them without at least a key wire, or they will move just right after the surgery. Do you have any tips?
Exactly.
Do you have any tips for this to fix this those very, very small fragments, glue or something? No experience with this?
Glue? To use glue? No. I use it
Pedro.
Just one time.
Yes. Sorry, Gustavo. Pedro is.
No. It's okay. It's okay. I want to hear Pedro too.
Pedro.
No, in fact, that's as Gustavo said, the small fragments are so difficult to fix, probably with key wires or anything you can fix. But as I told before, using about grafting, also you can have a basis to fix the fragment. And also for small cases, very, very small cases, very small fragments, especially in the articular surface, you can fix using fibrine glue, because the objective is to have a line, okay, completely for these special fragments. The problem that is not always is possible to fix in many countries or many centers. But with fibrine glue, it's perfect, because we perform a second look in patients treated with this technique, and the surface is perfect. I recommend it.
Thank you. We have Rene and Logan. Yes.
Yes, I have a comment, and I have one question to Noelia and Gustavo.
Fantastic presentation and cases as always, Noelia, Gustavo, huh? And animation. Gustavo, in your experience, when we know what is your treatment on the distal radius fractal and comminuted fragment. What is your opinion with and your experience with we have associated injuries, and what percentage of your cases we have a TFCC tears in the foveal part and scapholunate lunotrigetal. In these cases, when we have a lot of fragment in the distal radius case, huh? And on the second question, when found in the distal radius part and the chondral injury and the important chondral injury in the distal the facet of the scaphoid of the lunate, what is your treatment in this moment? Thank you.
Thank you very much, Rene. Well, that's a very interesting question because I think that associated injuries is still a big discussion in wrist arthroscopy because there are a group of surgeons that are convinced that we must treat them, and there are a group of surgeons that think that perhaps we are talking about a very acute injury in where we have a big potential to heal the injuries of the wrist. So I think in my experience that I'm careful to have a good alignment of everything, a good alignment of the distal radial ulnar joint, a good alignment of the scapholunate joint, a good alignment of the lunotriquetral joint, and then I think that the biology do the rest. I have to be honest with you, and I don't do all the suture or repair in each ligament I found with an injury or a torn, because I really think that the biology do the rest during the 2 or 3 weeks after the surgery, because we are talking about an acute injury. But of course, if I have a malalignment of the carpus, for example, I have a big dissociation of the scapholunate joint, I have a dorsal subluxation of the scaphoid, or I have a DC deformity, of course, I treat them and I try to realign the carpus. But I think that the biology do the rest during the next days. So I don't give too much importance if I see just a detachment of the TFCC. I not always do a foveal reattachment. That's the first question. Sorry, can you repeat me, Rene, the second one?
When we have the chondral injury in the first moment when you're evaluated of the radiocarpal joint.
Well, I think we cannot do anything with of course. The most important thing in this acute moment is to document this injury of the cartilage and tell to the patient that the cartilage has suffered a lot just with the high energy of the initial trauma. But we have to tell to the patient, to speak with the patient, that perhaps he or she may develop some arthritis of the radiocarpal joint, and perhaps we have to do a new procedure in the future. But the reality is that we don't know if he or she will do the arthritis in any way. So I think that we have to talk with patients and tell to the patient and show to the patient the injury of the cartilage. Just that.
Thank you, Gustavo. I think we can take maybe a last comment or question from Logan, because she's asking. Logan?
Yes, beautiful presentation, great case, and your animations were impressive and actually really helped drive home, what you're trying to fix. So great presentation. I think it was really great because it makes you think about your approach. Sometimes we might approach distal radius fractures with a very standard way of, doing the fixation first and then going to arthroscopy, and really makes you think about the fracture you have at hand and look for those fragments. It's probably more common than what we realize that they have these depressed fragments. And so, if you go ahead with a distal radius fixation first, then you're really scuppering you're scuppered, because then you have this depressed fragment that you can't get out. A question for you is your post-op range of motion protocol any different with these types of patients who you've had to fix this depressed fragment? Just if there's any difference.
Well, thank you so much for your comment, Logan. I totally agree with you. And I don't change my protocol of rehabilitation after this kind of surgery, because if I'm sure that these fragments have a good stability in the intraoperative moment that I check it with the probe, touching those fragments, as Noelia showed during the arthroscopy, so I know they are not going to collapse after the surgery. So I treat them in the same way that any distal radius fracture, like a Putot calls an extra-articular fracture. I hold them just with a bandage for swelling control for 10 or 12 days. And after that, at 2 weeks, exactly at 2 weeks after surgery, they start the physical therapy. But before that, of course, they move the fingers, they try to move a little bit the wrist, and that's it. I just change a little bit the protocol of rehabilitation. If I found a big injury of the ligaments, as I was speaking with Rene, perhaps that can change a little bit the rehabilitation protocol. But if I'm sure that the fragments have a good stability, I don't change it. Thank you.
Thank you, Gustavo and Logan. I just would like to share what I do for the associated scapulohumeral injuries, instabilities. We don't have enough level of evidence for the instabilities less than EWAS 3C to treat them. We are not sure it is necessary to treat them. Personally, I treat only the instabilities greater than or equivalent or greater than EWAS 3C. And I immobilize the patient for 3 weeks. That is my protocol. And I don't know if anyone else would like to share his or her protocol for the acute scapulohumeral instabilities for distal radius fracture. We understood that Gustavo never treat them? No, you never treat them, Gustavo?
So the scapulohumeral injuries?
Yes.
Well, I just do realignment of the carpus, and I just do, if I see a big injury, I just do a capsulodesis, but I never go to reconstruction or to ligamentoplasty. I'm sure about that. I never do it, a ligamentoplasty in an acute distal radius fracture.
I agree. And
this is also my experience.
Lucian, which grade do you treat with a capsulodesis, for example?
In acute?
Yes, associated with distal radius fracture in the acute cases.
If I see that the ligament is really detached and the space is really opened, I do the technique Pedro taught me, putting an anchor and suturing the capsula to the scaphoid and the lunate, doing a capsulodesis with anchor.
So the high grade EWAS 3C at least.
Yeah.
Okay. And Pedro,
in acute cases,
yes, we are talking about the associated.
Yeah.
And Pedro, could you share, please, just maybe to conclude, because we are 2 hours, your experience? Which stages do you treat in the acute cases associated with distal radius fracture?
Well, my experience is normally there are no so huge defects in the scapulohumeral space with this type of fracture. Normally, we didn't use any treatment, as Gustavo said, and then only rest during 2-3 weeks are normal. It's the same protocol. But you have a case with a grade 3 or 4 also. probably in this case, we treat with using a capsulodesis. In this case, using two anchors, one on the scaphoid, another one in the neonate. But there are not many cases that you need to treat with this technique, normally.
Because these cases are very rare. I think there are less than 20%, I think, about all the cases. Thank you, Pedro.
And for the TFCC, I agree with Gustavo. It's really, really, really rare to fix a TFCC in acute. It's more a chronic situation.
So, any other comments? Otherwise, I think we can end the webinar for today. I think it's okay. Thank you. So I think it is the end. Thank you for the great cases. It was very interesting, and congratulations for the results. Thank you to all the panelists for joining once again. The next meeting is in 1 month on September 13, and you will have, as usually, the link to register on the Instagram and the LinkedIn account. So once again, thank you, and have a nice weekend, everyone. Goodbye.
Bye.
Thank you, everybody. Bye.
Bye. Thank you.
Thank you.